Hello, everyone, and welcome to the Dr. R Show. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Meet my two very special assistants, Megan and Christina.
And I am so excited because today is leg day.
And then inhale as you lower back down.
They will be with me every week to give us tips on healthy eating and proper exercise.
Stretch and keep yourself hydrated.
So welcome to my show as we both learn together. Hello, everyone, and welcome to the Dr. R Show. You may be wondering, who is Dr. R and why is he on TV? Well, let me tell you a little bit about myself and how I ended up here. I've been a medical doctor since I graduated medical school at Johns Hopkins in 1979. I then trained for 6 years in neurosurgery at UT Southwestern in Dallas at Parkland Hospital. For those of you who don't remember, Parkland was the hospital they took President Kennedy to after he was shot in 1963. As you might imagine, training to be a neurosurgeon can be very demanding and takes quite a long time. I finally finished my training at age 30, which is when I started my practice in neurosurgery, where I performed brain and spine surgeries. Everything was going great until I hit age 50, at which point I began to feel the effects of aging. Aging is an interesting phenomenon. As we get older and older, the definition of aging gets pushed further and further into time. When we are 20, we think old age is when we hit 50. When we are 50, we think old age is when we hit 70. And when we hit 70, we think that old age is when we turn 90. However, chronologic age often does not correlate with our biologic age. Biologically, we can be much older than what the calendar is telling us. It all comes down to health span, which is that amount of time in one's life where we are in optimal health. What we all want to avoid is the inevitable onset of frailty and feebleness as we get older. With modern medicine, we keep people alive longer, but their quality of life often continues to decline. Traditional medicine has become very good at treating symptoms, but not so good at getting to the root cause of some illnesses. That is exactly what happened to me when I hit 50. I had always been a high-energy guy, working 16-plus hours a day, taking care of various neurosurgical problems, which often were emergencies occurring at any time, day or night. This environment made it very difficult to live a healthy lifestyle. As you can see by my before pictures, the effects of poor lifestyle choices and stress can be dramatic. This is the situation I faced in my early 50s. I hit a brick wall, and so my energy levels plummeted, and my waistline expanded no matter what I did. I finally realized I had hit the beginnings of old age, but I refused to give in to what many think is the inevitable, the gradual decline of function that ultimately leads to feebleness and frailty. I still was not ready for that. That is when I developed an interest in aging and in the causes of aging. As it turns out, there are certain things that can be corrected as we age and some things that cannot. By focusing on what we can correct and influence, we can return our bodies to optimal health and expand our health spans, thus having an improved quality of life well into the future. Having developed a program for myself and seeing the dramatic effects it had, I decided to offer this to my patients as well, which brings us to why I'm here hosting a medical show. After great success with the program and my patients, I was offered the opportunity to share my knowledge and experience with a local audience. Now, if you are a doctor and a network asks you to do a show for them, you don't say no. So here I am. We'll be coming to your living rooms weekly to discuss various health topics with the help of medical experts in their respective fields. Now, some of you may be thinking, hey, this guy looks like Dr. Oz. I get this comment all the time when I'm out in public. When I'm not Dr. Oz, I am Dr. R. I have gray hair, he doesn't. I am 6 years older, he is 6 years younger. He is a heart surgeon, and I'm a brain and spine surgeon. He went to medical school at the University of Pennsylvania, and I went to Johns Hopkins. He's a great TV host, and I'm just getting started. So welcome to my show as we both learn together. I would like to introduce to everyone my two lovely assistants, Megan Paul and Christina Conley. They will be with me every week to give us tips on healthy eating and proper exercise. In the planning stages of this show, when we were searching for the ideal person for this segment, we debated between having Mr. Olympia or having Megan and Christina. Our panel of advisors, me, made the obvious choice. I think you'll all agree. Megan Megan has her Master's of Science in Kinesiology and Sports Studies with a concentration in exercise science. Christina is a passionate overall health nut who is self-taught. Together, they make a great combination and will give us a well-rounded perspective on these topics. Megan, what got you interested in health and fitness?
I would have to say back in high school when I was doing cross country and track, I just really loved the way running made me feel, both physically and mentally. And so running's just been a part of my life ever since. And then I decided to pursue a degree in it so that I could help other people become healthy as well.
Christina, what got you into fitness and nutrition?
So when I was actually in high school, of course, I played sports as well, and you know, you do a lot of working out in high school. And then I decided I wanted to become a model, so I started modeling, and I realized that, you know, it's very restricted, the size that you have to be, and then it just became sort of frustrating because I was doing it more for just how I looked rather than how I felt. And, you know, of course, when you feel good, you look good, so I thought that was really important in, you know, learning more about exercise and nutrition.
Megan, can you give us a few tips on how to stay motivated to exercise on a regular basis?
Well, there's one quote that we heard that I think really stuck with both of us, and it's that a 1-hour workout is only 4% of your day. So we often say that we don't have enough time for exercise, we can't fit it into our busy schedule, but when you think that it's only 4%, I think we're spending a lot of time doing other things like scrolling on the internet, so we just need to make it a priority.
So how much time do you recommend? How many times a week should one exercise?
According to the American College of Sports Medicine, we need 5 days per week, a minimum of 30 minutes per day of aerobic exercise at moderate intensity. And in addition, we need to do 2 to 3 days a week of resistance training for each muscle group, and make sure that you're resting for 48 hours in between sessions.
Well, that's really not a lot of time for the benefits that you're getting from it.
Yes.
Yeah. Christina, if you had to offer one tip on fitness, what would that be?
Now, don't be so hard on yourself. I think that's my biggest tip, because I think a lot of people, you'll go into a yoga class or you'll go into the gym and you're so concerned with all of the super fit people that are in there, and you think that they're sitting there judging you. They're not. They didn't look like that at one point. It took them a long time to get there with, you know, strict diet and a fitness regimen. So just don't be so hard on yourself. Enjoy what you're doing. If you're not enjoying it, you're not going to be consistent with it. So if you're doing a workout that you absolutely can't stand, I wouldn't recommend doing it. Find a way to alter it to make it more enjoyable and more fun.
And if you had to offer a tip on nutrition, what would that be?
Everything in moderation.
And is it true that you taught New Yorkers how to speak?
I did not. See, people think I talk so fast, and I just think that that's not true. Is that true?
I'm from New York.
You're from New York?
And you speak faster than I do.
Well, see, I mean, clearly I teach you everything you know. So, I mean, you're welcome, Dr. R. The success of the show is all thanks to me.
Well, Megan and Christina, I want to thank you both for being an important part of the show.
Thank you.
It'll be great seeing your fine examples of healthy eating and proper exercise, and I'm sure the audience will enjoy the break from having to look at me all the time.
You're welcome.
Thanks again, ladies.
Thank you.
And we'll be right back.
Oh, dear. That was awful. My answer.
I'm here with Dr. Richard Bevan Thomas, Director of the USMD Cancer Center. Dr. Thomas, thank you for joining us today and helping to explain to our audience the prostate and what could potentially go wrong with it.
Glad to be here. Thanks, Jay. Appreciate it.
So what is the prostate? What does it do?
So the prostate is a small gland that is actually located just below the bladder. The prostate is unique to men, so women obviously don't have a prostate, but some have asked me that question before. And the prostate is in charge. It's a reproductive organ, so that when a man ejaculates, roughly about 90% of the ejaculate actually comes from the prostate itself. So it's very important, obviously, for reproduction.
Tell us a little bit about the anatomy and the structure of the prostate.
Yeah, so right below the bladder is the prostate, and the prostate can be as small as a walnut. People have described the prostate being walnut-sized, and that's probably true for men in their 20s or 30s, but it can also be as big as an orange, you know, sometimes. So, I mean, it can be very varied in size, and as a man gets older, that prostate will continue to increase in size. It doesn't necessarily correlate with the size of the prostate actually causing urinary symptoms, but again, so because you're urinating right through the middle of the prostate, that can block off the urinary channel. So urination-wise, it can affect it, as well as reproductive-wise.
So with the prostate, does size matter?
So it does. So as that bigger the prostate, there is a likely correlation that as the prostate increases in size, there is a more likely chance that that man is actually going to have troubles actually urinating, and obviously, again, blocking off that flow. And that's when men actually start waking up in the middle of the night, they can't urinate as well, and they have a slow stream.
What kind of tissue is inside the prostate? Is it muscle tissue? Is it gland tissue? Is it a combination of both?
Great question. So it's actually a gland, and so that gland actually produces that fluid. So again, when a man ejaculates, so it's not muscle tissue, but that gland, those glands actually all coalesce together, and they basically squeeze out, and that's where that fluid actually comes out right through the middle of that prostate. Again, right through the middle of that donut, so to speak.
Are hormones important to the prostate?
So they are important. But so as a man gets older, what happens is that a man's testosterone will tend to decrease. But what happens is that that prostate will start to decrease from a number of different hormones that actually start increasing the growth of that prostate, which is why when we see men in their 70s and 80s, we start seeing they have more and more problems with urination. And that's a challenge, is that, you know, if you block off those hormones, can you decrease the growth of that prostate? And we can, but again, there's also side effects with that as well.
Now, many people think testosterone causes prostate cancer. Is there any truth to that?
So there is no truth to that, and that's a fascinating question, is that for years, what we did know is we knew that if we shut down the testosterone production in men, we knew that men with advanced prostate cancer, we could actually slow the growth rate of prostate cancer. Now, that was actually true, and this was actually down in the 1940s that we figured this out. So we sort of backtracked and we said, well, okay, if that was the case, then it must very well be the case that if we give a man testosterone, that will cause that prostate cancer to grow, and that's actually false. And that's actually never been, there's no studies to prove that. What we do know is we know that there is a risk for men with actually lower testosterone and the potential that they may increase their risk of prostate cancer. So it's not like every man should be on testosterone, but I think we have to be very careful about not putting a man on testosterone because of their risk of developing prostate cancer, because there's very limited data to support that theory.
So if you maintain normal testosterone levels, will that protect you from prostate cancer? Since the group of men with lower testosterone levels are the ones that get prostate cancer.
And that hasn't been proven yet. So if we can actually maintain a man with normal testosterone levels, will that decrease his risk? Well, again, a study that we discussed recently, and I sent you that paper, that looked at men actually with normal testosterone levels, there is the potential, again, a small study, but we're looking at this more and more in the urology community, a smaller study, and we'll see more and more, that if we actually normalize those men's testosterone, can we decrease the risk of prostate cancer? And I would posit to you that I think that there is a good chance that we will prove that we can potentially decrease those men's risks, but I think the data, and again, the studies need to be performed.
So why is it the perception out there in the medical community that testosterone causes prostate cancer? I hear this every day.
Right, so there's a lot of misconceived perceptions out there. Unfortunately, one of the perceptions is that prostate cancer is an indolent disease. Nobody dies of this disease, and we'll talk about that a little bit later. You know, I think it really started when the fact that, you know, with testosterone, and again, back in the 1940s, when we figured out that when we stopped testosterone, we could actually decrease the growth of those patients with advanced prostate cancer. And again, that sort of continued to progress in the fact that if we gave a man testosterone, we would subsequently increase his risk of prostate cancer. Again, very limited data to support that. But like many things in medicine, we really want to prove those before we start, you know, espousing those to our patients.
We need to take a quick break, and we'll be right back.
Hey guys, welcome to Inside Fitness. I'm Megan and this is Christina, and today we're going to be talking about the general guidelines of fitness.
Before starting any exercise program, you really want to make sure that you understand the fundamentals of both aerobic exercise and strength training. If you're able to incorporate both of these into your workout, then you'll make sure you're training your body at the maximum capacity, adding variety and making it a little more fun.
That's right, and the American College of Sports Medicine recommends a minimum of 5 days per week and 30 minutes per day to equal at least a minimum of 150 minutes per week of aerobic exercise.
So that's for aerobics, but also there is strength training. We also recommend that you do your strength training at least 2 to 3 times a week per muscle group.
But your muscles do need adequate rest time in between workouts, so be sure to rest them for 48 hours in between each workout session.
So quit making excuses. Your workout is only 30 minutes a day, and that's the 2% part of your day that's going to make 100% of the difference.
So there are 5 health-related components of fitness that you really need to focus on, and you never ever want to skip leg day.
Exactly. The first one is going to be cardio endurance, or affectionately referred to as cardio. Now, when you're first starting to work out, this is something that's going to be raising your heart rate and really putting you in that optimal fat burning state. So in doing this, you want to be able to walk brisk enough to where you can still carry a conversation, but it's a little bit laborious. And as you get in better shape, you'll be able to increase that to jogging or running. If you are worried about your joints, however, there are a couple other options for you to be able to do, like the cycle or the elliptical. Then we have the muscle strength and muscle endurance. When you're lifting weights, the actual weight that you're lifting pertains to your strength, and the endurance pertains to how many reps or repetitions. When first starting out any workout, I recommend trying any muscle strength endurance exercise 3 sets of 10.
Now there's flexibility, and you never want to forget to stretch. Stretching is really important after every workout because as you're lifting weights and as you're getting stronger, your muscles are actually going to become stiff. Flexibility stretches your tendons and it makes room for muscle growth, and it feels really good after a workout. Then we also have body composition, which is determined by the percentages of fat, muscle, bone, and water that's in the human body. Now body composition is what determines our leanness, so don't pay so much attention to the number on the scale. It's more about what your body is made up of.
All right, guys, we've given you a lot to think about this week. We will be back here same time next week for Inside Fitness. Make sure that you're doing those 30-minute workouts, you're incorporating your aerobics and your strength training. Always stay hydrated and remember to stretch. We'll see you next week.
We're back with Dr. Bevan Thomas. Dr. Thomas, let's talk about prostate cancer. How common is prostate cancer?
So prostate cancer is unfortunately very common. So if we look statistically, a man's risk of developing prostate cancer in his lifetime is roughly about 1 in 6 to 1 in 7. So if we look at it to pure numbers, which I think is important for patients, is that it's, in 2015, it's estimated that roughly 220,000 men will be diagnosed with prostate cancer. So one of the challenges with prostate cancer is, like testosterone in prostate cancer as well, is that, we have unfortunately these myths out there and these fallacies, which is prostate cancer is all an indolent and benign disease. Now that's partially correct, and I think one of the things that we have to look at is how many people die of prostate cancer. Roughly 27,000 men, to be estimated, so about 27,500 men die of prostate cancer every year. It is a legitimate disease. It is the second most common risk of death, second only to lung cancer. People will die of this disease, and it's an important fact to understand because people think prostate cancer, nobody dies of that, right? It's also a very important thing to realize is that not all prostate cancer behaves the same. So we can have patients with low-grade cancer, we have patients with intermediate-grade cancer, and high-grade cancer. And it's important that you don't, I tell people this all the time, don't go over to the golf course and say, well, oh yeah, nobody dies of prostate cancer. I had prostate cancer and I'm just following it, because it's a different spectrum of diseases.
So how do you know which patients have the more indolent form versus the more benign form?
Yeah, and that is a $64,000 question that we address every day. So, how do we detect prostate cancer? That's the first question we always ask ourselves. And we still actually, number one is we'll do a physical exam. So we still have the, the infamous rectal exam, which all men, of course, dread. And the second thing is a PSA. And the PSA is a blood test. And when we look at that blood test, PSA stands for prostate-specific antigen. It's a protein, and that protein is produced by the prostate. And then basically, I tell people it's sort of like the prostate's a leaky pipe, and it leaks a little bit out through the bloodstream. But if that pipe is leaking a lot, we got some problems. So as that PSA, again, gets out in the bloodstream and we start seeing that high, we then find that man is at risk of having a focus of cancer. So what we've been doing, for quite some time now, is that if a man presents either with that abnormal rectal exam or with that PSA, that blood test which is elevated, we bring them in, we'll validate that PSA to, again, make sure that that's elevated. And normally right now it's above 2.5 or 3. So if you're a man with an elevated PSA above 2.5 or 3, we'll say, you know what, it's at least a good idea for us to investigate whether we need to do a biopsy. The only way we know whether a man has, whether it's low-grade, intermediate-grade, or high-grade cancer, unfortunately, is to get tissue. And the way that we do that is actually do that prostate biopsy.
So now, can you have prostate cancer and have a normal PSA?
You can. And this is one of the challenges, is that, roughly about 20%, and somewhere in the ballpark about 10 to 20% of men actually can have a normal PSA. Of course, what's your definition of a normal PSA? When the PSA test first came out in the late 1980s and really 1990s when we started testing and actually screening for prostate cancer, we used a PSA cutoff of 4.0. But if we used a cutoff PSA of 1.0, we would still find roughly about 10% of men actually had a focus of cancer. So we wanted to find that happy medium that we're really not missing a bunch of these patients. But give or take, it's about 2.5 or 3. As men get older, you might want to raise that just a tad, but the bottom line is that a PSA gets higher, increased risk in that. But you're right. The problem is that there are those men that have a normal PSA and have a risk of prostate cancer. So that's where the rectal exam comes in. That PSA is, let's make it up and say it's 1.8, but we do that rectal exam and we actually feel a bump on the prostate and we say, you know what, we really want to make sure that we're not missing anything, and then we'll find that focus of cancer.
And how often is a prostate biopsy positive in a situation where you have an elevated PSA?
Right. So what happens is that as that, and it is a linear progression, which is that as that PSA continues to increase, there's a higher risk that that man can have a focus of cancer. One of the challenges that we've had, at least more recently, is actually finding those cancers. What we do is we actually will do, man walks in exactly like you and says, okay, I've got a PSA of 2.7, we'll do a biopsy. We'll do the biopsy, again, we'll sample, and we try to target it. USMD will actually try to target specific areas in the prostate, but we may miss something. And the risk of finding what we call a significant focus of cancer is still relatively low. It's roughly below about 20%. But now what's happened is things have changed. So now we're starting to use more imaging technologies to help us find those cancers. So what we'll do now is we'll do MRIs, and the MRI, which has become much better these days, will find a lesion which may be significant. We then pull that MRI over to that ultrasound, and then we'll target that lesion. So now we've increased our detection methods, but give or take about double for men either with a previous negative biopsy or men exactly who walk in with a PSA of 3 or 4, so we can target lesions that we can actually see under imaging studies.
How painful is prostate biopsy?
So that's, and that's a tough one. I mean, there are patients that actually say, come into our office and say, man, I just feel like I was completely tortured on this. So a lot of this actually does a couple of things. Number one is that it's no fun. I'll tell people it's like a 10-minute rectal exam. And again, there's nothing fun about a 10-minute rectal exam. But the bottom line is that what people mainly have discomfort with is the actual biopsy itself. So we're very good, and I pride ourselves on this in the fact that if we can anesthetize, and we'll put lidocaine, numbing medication, around the prostate, so before we actually do those biopsies, all those men should feel is sort of a little flick for the most part. So they're going to feel pressure, but they shouldn't feel anything sharp. If they do, and again, we do about 95, 90, 80% of these actually at our office, is that we can always give them more lidocaine or more numbing medication so they actually just have very minimal issues. And we've actually done that, and we've asked our patients, and they say, you know what, this was a lot easier than I actually thought it was going to be.
Any complications with prostate biopsies?
So we do. And so what's happened over the last 10 years is that we've had an overuse of antibiotics. And that's one of the biggest challenges, is that if we use too many antibiotics, we run the risk of infection. So one of the risks of infection is infection. So we want to make sure that we're treating them with the appropriate antibiotics to minimize the chance of actually developing an infection. We target that down. So we want to make sure that, again, if the appropriate antibiotic is used, we can minimize that infection at less than 1%.
Well, Dr. Thomas, thank you very much. It's all the time we have. We'll see everyone next week.